Go ahead.
Hi, I'm Katie, and this is Cassidy, Roselle, Mina, and Jessica. We're going to be talking about the use of proning in patients with respiratory distress today. Proning is the process of carefully turning patients from the supine to the prone position or laying on the abdomen. This helps to expand the back sides of the lungs to improve ventilation and clearance of secretions. Because of the emergence of proning during COVID-19 as an intervention to improve symptoms of respiratory distress in patients, we hope to research if proning reduces incidences of intubation requiring ventilation. Our PICO question is, in ICU patients experiencing respiratory distress, does placing the patient in a prone position versus not proning reduce the rate of intubation? This topic is important to investigate because acute respiratory distress syndrome is a life-threatening illness that happens from injury to the lungs from several conditions, including COVID. Fluid leaks into the lungs and results in a difficulty breathing. Without intervention, patients will die from the lack of oxygen in their bodies. While less severe cases of respiratory distress are treated with face masks or a nasal cannula, more severe cases require intubation and mechanical ventilation. However, mechanical ventilators have been associated with complications like pneumonia and sepsis and with increased rates of morbidity and mortality. The concern with this practice is that it emerged during the COVID-19 pandemic and was not widely known before. Since it became a more common practice during this time with intubated patients, we wanted to research if this topic would help to improve ventilation and oxygenation in patients and prevent the need for intubation.
We chose 10 articles for our research. The criteria for choosing the sources were as follows. They had to be written in English, be no older than 5 years, come from peer-reviewed sources, have high level of evidence if possible with one exception, but we'll get to that, and be relevant to PICOT question. The databases we used were EBSCO, PubMed, CINAHL, NCBI, and JAMA. We used the following keywords: respiratory, ARDS, proning, systematic review, RTC, and intubation. Here's the overview of our findings. Ayin and others in 2021 did a systematic review and meta-analysis with 1,272 patients with confidence interval level at 95%. That was level 1 evidence. They found that prone positioning may improve oxygenation, lower intubation, and mortality rate. The limitations were low differentiation of groups and unclear estimations. Strengths were large sample size and the newness of the study. Fazini and others in 2022 did a systematic review and meta-analysis with 2,352 patients and p-value less than 0.05. That was level 1 evidence. They found that proning improved oxygenation, reduced mortality rate, but may or may not reduce intubation rates. The limitations were the risk of potential bias, frequency and duration of proning was not explored. The strengths were the large sample size and the newness of the study. Feast and others in 2020 did a systematic review with 414 patients. That was level 1 evidence. They found that proning improved oxygenation and reduced rate of intubation. The limitations were the small sample size and the lack of control group. The strength was the relevancy to our PICOT question. Jelic and others in 2020 did a single center cohort study with 88 patients and p-value less than 0.05. That was level 5 evidence. They found that proning improved oxygenation and reduced intubation rates. The limitations were small group size and lack of control group. The strength was the relevance to our PICOT question. Oliveira and others in 2021 did a single center observational prospective study with 41 patients and p-values of less than 0.05 and less than 0.01. That was level 5 evidence. They found that proning improved oxygenation, lowered risk of mortality, and lowered intubation rate by 54%. The limitations were small sample, it was only a single center study, and intubation depends on provider discretion. The study only related to COVID-induced ARDS. The strengths were in the fact that several respiratory parameters were included and high statistical significance. 10 and others in 2021 did a meta-analysis with 243 patients and a very low p-value. That was level 1 evidence. They found that proning improved oxygenation, proning over 5 hours lessened intubation rate by 13%. The limitations were small sample, most patients had COVID-19, lack of RTCs on the same subject, lack of clarity regarding timing of proning. The strength was in the strong statistical significance. Powers and others in 2021 did a retrospective descriptive study with 46 patients that was level 5 evidence. They found that proning improved oxygenation, prevented transfer to ICU, and prevented intubation. The limitations were the small sample size, proning frequency and duration varied, and additional studies were needed. The strength was in the study relevance to our Picot question. Pavlov and others in 2022 did a systematic review with 2,994 patients and p-value 0.71. That was level 1 evidence. They found that proning improved oxygenation, but did not show improvement in intubation rates. The limitation was the low statistical significance of this study. The strengths were in lack of bias and the large sample size. Ehrman and others in 2021 did an international randomized controlled meta-trial with 1,211 patients that was level 4 evidence. They found that prone positioning reduced intubation rate by 6%. The limitation was the conflict of interest in funding. The strength was in the large sample. Stillma and others in 2021 expressed an expert opinion from a variety of international experts. That was level 7 evidence. They found that proning was a safe adjunctive treatment in hypoxemia refractory to supplemental oxygen in patients with ARF due to COVID-19. In settings with low number of ventilators, it is a safe and cheap option in improving oxygenation. The limitation was in the low level of evidence. The strength was in the fact that best practices of proning were summarized and utilized by us for comparison with the local protocols. The conclusion of the review is as follows. Out of 10 chosen studies, 7 indicated a reduction in intubation rates in patients with ARDS or patients with COVID-induced ARDS. 2 studies did not show a definitive improvement in the intubation rate. 1 study confirmed proning as a safe and inexpensive adjunctive treatment if ventilation is not available. For the research of practical guidelines, we went to World Health Organization first, who in 2020 recommended to prone children and adults for at least 12 to 16 hours daily and suggested that human resources and expertise were needed for turning prone patients. They suggested to place pregnant patients in lateral decubitus position because proning was not explored for this group. The CDC disseminated a PowerPoint for COVID-induced ARDS in 2020. In it, they recommended to prone patients for at least 12 to 16 hours daily. They suggested that ventilated proning is preferred to ventilated supine position. Long Beach Memorial Center policy from 2020 states that proning must be done with a doctor's order by a registered nurse who completed a competency checklist. A transpyloric feeding tube must be placed to prevent aspiration. Ocular lubricant should be applied every 4 hours and patient tilted every 2 hours. The contraindications include unstable axial fractures, cervical skeletal traction, high ICP, weight over 350 pounds, heart rate less than 30 for over 30 seconds, and or MAP less than 40 for over 5 minutes. Discontinue proning if FiO2 is 0 or less than 0.5 and PEEP less than 10. These practices are concurrent with recommendations by Stillma and others published in 2021 in the Journal of Tropical Medicine and Hygiene. The LBMC policy referenced UCLA policy, so it can be assumed that there are many similarities between the two.
For recommendations, we decided on 3 guidelines based on our research. The first recommendation when implementing proning is to utilize proning early in the treatment of severe ARDS as a lung protective strategy rather than during the late stages as a last resort. A study by Schulten found that prone positioning has not been found to improve survival rates when used during late treatment. A study completed in 2016 found that only 16.3% of patients with severe ARDS were treated with prone positioning. Because hospitals may require a physician's order to implement proning, an important nursing consideration would be to advocate to have proning included in the plan of care. For the second recommendation, patients should be in the prone position for at least 12 hours per day in order to ensure effectiveness. A meta-analysis by Munshi showed a lower mortality rate for patients who were prone for over 12 hours. Long Beach Memorial has a proning policy of 16 hours per day, but that time frame is based on a clinical trial of intubated patients, so non-intubated patients may have different needs.
Our third recommendation for implementing proning in patients with ARDS is to train staff on the maneuver. Proning should be implemented with experienced staff to avoid mistakes or risks that might be seen with learning how to prone. One study by Schulten and colleagues showed all staff had used proning in daily practice for at least 5 years, which promoted more optimal patient outcomes when compared to other similar studies. A proning competency checklist may be used to make sure that there is proper implementation and avoid the use of proning in contraindicated patient cases. This checklist will also help less experienced staff to become more experienced with each component that is needed for proning and help reinforce those components for the experienced staff.
In regards to financial implications, not enough research has been done on the cost of proning. It may seem as if this intervention is not costly since healthcare professionals and assistive personnel are already being paid to provide patient care. Proning can simply be added to the list of tasks that need to be completed, but it can be associated with an increase in use of personal protective equipment, or PPE, which can drive up facility costs. However, if the intervention can decrease intubation rates and the length of stay in the ICU, it could translate into substantial cost savings despite the higher facility spending on PPE.
Looking at the need for future study, the most recent studies focusing on proning non-intubated patients available are mostly observational prospective studies, and the meta-analysis studies accessible reference research trials with smaller sample sizes. In the next 5 years, research should be planned with larger sample sizes with the use of randomized control trials. Larger sample sizes would be more generalizable to the population and are more accurate. Additional randomized control trials will reduce bias in the studies. The larger randomized controlled trials should focus on larger populations, such as a variety of hospital units or settings, and larger geographical parameters, standardized control groups, and larger sample sizes in general. Specific parameters should include time spent proning, frequency of proning, oxygen monitoring during and after proning, and identification of adverse events such as intubation and death. The standardization of study protocols would allow for better comparison between results on varying duration of proning. For example, one group may be prone for 12 hours while the other is prone for 16, and you would be able to compare the improvement of respiratory status. Due to the recent prevalence of ARDS in the setting of COVID-19, much of the research is a preliminary assessment of the efficacy of awake proning, which will help to structure more concrete, specific, and repeatable studies on this subject in the future. So to summarize, awake proning is an additional intervention that can be taken during the preliminary stages of ARDS to decrease oxygenation by improving ventilation. Our PICO question looked at or asked, in intensive care unit patients experiencing respiratory distress, does placing the patient in a prone position versus not proning reduce the rate of intubation? Of the 10 studies reviewed in this paper, the majority found that awake proning was associated with decreased rates of intubation. To implement awake proning in the hospital setting, we detailed the current clinical practice guidelines established by WHO, the CDC, and American Journal of Tropical Medicine. Future studies should focus on randomized control trials with larger sample sizes and specific parameters such as frequency, duration, and efficacy of proning, which will allow for the establishment of evidence-based protocols and standardized guidelines for awake proning in all critical care and hospital settings. Currently, awake proning is understood to be a promising intervention that can increase oxygenation and decrease the need for mechanical ventilation. Thank you so much for listening.